to the National Foundation of Swallowing Disorder webinar series. My name is Ed Seeger. I'm president of the foundation, and I'm also a head and neck cancer survivor diagnosed with severe dysphagia in 2007. I want to thank you for attending tonight. As most of you know, the mission of the foundation is to provide support for all of those with a swallowing disorder and improving their quality of life. And we do that through direct patient support, providing educational programs, raising swallowing disorder awareness, and helping to fund promising translational research. Many of you may also know that June is National Dysphagia Awareness Month, and we have many programs on Facebook and Instagram and other social media assets that will help to raise awareness of this invisible disorder. During the webinar, you will be muted, and to ask a question, please click on the blue question mark to type it in at any time, and we'll pass that to the presenters. Next slide, please. I do have an actual volunteer opportunity to share with you for those who are head and neck cancer survivors. There is research currently taking place being led by Jan Pryor, who is a doctoral student at the University of Washington. But she's so much more than that. She helped create this foundation 15 years ago. She has been a board member of the foundation for 15 years. And she runs our support groups for patients and actually helped create 15 in-person support groups around the country before the pandemic hit. Some of those are now restarted. So Jan is approaching the end of her doctoral thesis, and she had a short survey. So if you meet the criteria of being a head and neck cancer survivor, we'd like to connect you with Jan, and there will be information about that in the post-webinar email. So I encourage you to take 10 or 15 minutes, if you haven't already, and fill out the survey. This webinar was made free of charge thanks to the generosity of an unrestricted educational grant provided by Bracco Diagnostics and also other sponsors, Mirror GTX, Radio Rehab, and Tim's Medical. I'd like to introduce our guest keynote speakers for tonight, Carie Montesa and Liza Blumenfeld. And they have invited a guest of their own, and I'll let them introduce him when they come on. Both have volunteered their time for this webinar, and the foundation, and I personally am grateful for that. Carie and Liza worked together at the University of California, San Diego Moores Cancer Center. Carie is board certified acute care nurse practitioner, and for the past several years has focused on Cancer Center's Survivorship program that aptly does what its name implies, long-term follow-up care to head and neck cancer patients. Liza is board certified in swallowing and swallowing disorders. She is also an NFOST board member. The foundation feels fortunate to have such a caring and knowledgeable medical SLP on our board. Liza's focus is complex head and neck cancer patients and patient-reported swallowing function and outcomes. And with that, I would like to turn this over to Carie and Liza and their special guest.
Thank you so much, Ed, for the warm introduction. You know, Liza and I are delighted to be here and speak with you all this evening. And actually, June is the National Cancer Survivorship month as well. So I think it's fitting that we have this topic tonight. And we're going to be talking about head and neck cancer survivorship from diagnosis, treatment, and beyond. We have to switch the screen. One second, I'm sorry. Just get this out of the way. Here we go. Can we get rid of this? No. Okay. As you can imagine, receiving a cancer diagnosis can evoke a multitude of feelings, and know that this is normal. Not everyone will have the same reaction. Now, one may think, how in the world can someone feel grateful or relieved when receiving a cancer diagnosis, and others feel complete and utter despair? The reactions can vary based on one's social and cultural norms and experiences with health and illness. In 2020, Kirby et al. Did a study to explore patients' accounts of their experiences receiving a cancer diagnosis, and it was found that patients can perceive and experience this in diverse ways. With an incongruent diagnosis, the diagnosis does not fit in with a person's healthy identity. They're feeling well, they aren't in pain, and having cancer just doesn't feel like what they thought it would. This can obviously cause initial shock and surprise. With an incidental diagnosis, the cancer is discovered coincidentally or by accident due to another health problem. Patients sometimes feel thankful and grateful for catching it, and it's sometimes like solving a problem. With a life context diagnosis, the cancer diagnosis could be less shocking or overwhelming if the patient is dealing with more challenging life events, such as death of a loved one. It's important as a provider to understand where someone may be coming from and openly communicate with patients about the reactions and experiences with a cancer diagnosis so that they may better support the patient throughout their cancer journey. So I'd like to introduce Carlos. Carlos is a head and neck cancer survivor and a UCSD patient. Both Lisa and I have had the pleasure of caring for Carlos throughout his cancer journey, so he holds a special place in our hearts. Carlos, can you please describe what it was like when you were told you have cancer?
Hello, everybody. Thank you for the introduction and for the opportunity to participate in the webinar. Let me tell you that I am 68 years old. I was diagnosed 3 years ago, and I could not have done it without the help of, number one, my family, the great staff at UCSD, and in particular, a good friend of mine, John Sheridan, who's also a cancer patient and survivor who had it before me and kind of held my hand through a lot of the processes. I think that the first initial reaction was, that can't be. Cancer happens to somebody else. It doesn't happen to me. I've been a good boy. I've been a good man. Why me? So it was somewhat difficult to hear it, even though finally, after hearing it, there was a little bit of doubt in my mind, because the doctor himself, one of the doctors, also had doubts. It's probably because of the procedure, of the medical procedure, but he's seen it many times, but he wouldn't commit to saying that it was cancer until after the biopsy was done. And then was confirmed that I had a 4.5 centimeter stage 3 cancer at the base of my tongue. And so all of this comes as a surprise. And next thing that goes through my mind is this something that I can live with? I knew nothing about cancer. I thought maybe it would just kind of stop growing, or if it grew, it would keep growing in a ball or mass that would be unobstructive. And when I asked my main doctor if it was something that I could live with, he answered, "Oh yes, you can live about 5 months." And that put everything a little bit more in perspective. I saw myself living a lot more than 5 months and reaching goals in my life that I had not yet achieved. So I went around for about 2 or 3 days afterwards with a big hole and knot in my stomach. And once I got over that, then I was kind of overwhelmed a little bit by a sense of urgency. Once I made the resolve to go ahead and go with this treatment and go with whatever it was that they were going to propose, the wait times seemed extremely long, and the times I'm talking about are all of the studies that need to be done, all of the programming that needs to be done on the radiation machine, and it just seemed like too long. But I knew that once I got started, that I had put my life in the hands of a great team. I searched for many doctors and found a couple of doctors that, to my surprise, were part of a team, and we just clicked. So I told my family, this is where I'm going to get treated, and that was at UCSD. My family started to worry and a lot, and kind of got sad about it. But my main concern is that I didn't want them to feel pity, and I wanted to maybe contain their emotions a bit, so that out of all of this, something positive would come out. And I will say that everybody rallied around me. And when I'm saying family, I'm talking not just my blood relatives, but my extended family, and many other people that were involved in my recuperation. I was also faced with logistical difficulties. I am from Mexico, and I decided to have my treatment here in San Diego. So I decided that I didn't want to have to cross the border or fly in or get tied up on the freeway. So my family ended up renting a place here in La Jolla, which is where I'm at today, and everything worked out just fine as far as logistics are concerned. And then the whole part of starts with studying about cancer, of which I knew nothing about, and what other treatments are there, what other options, and some of those included holistic treatments and CBD treatments and other cutting edge, or I will say that I was told that they were anecdotal references to improvements, but not scientifically proven. And at a research facility like at UCSD, it was something that they could not look into. But I was trying to connect with everybody around me that was going to be able to provide a service of getting me back to a healthy man that I was before. And I wanted to eliminate the unknown as much as possible. So I was always studying and asking questions and participating. And I will say also that aside from the technical parts of studying and learning, there was also trying to connect with feelings of myself, number one, but also in the back of my mind, maintain that logical thought. And I was doing that, speaking with the mathematicians, the dosimetrists, the physicists, the doctors, Liza. I was trying to get as much information as possible, and that really helped a lot in going ahead with the treatment after receiving the diagnosis.
Thank you so much, Carlos, for sharing your experiences with what it was like to receive your cancer diagnosis. Now, what are some of the things that people can do to help cope with a new cancer diagnosis? It's important to first recognize the feelings that one's having, and then to also share these feelings with others. Doing things that make you happy and you enjoy can also be really helpful. If one needs additional support, it's really important to seek that out. Cancer centers often have oncology navigators, social workers, and support groups that all can be extremely resourceful, not just at the time of diagnosis, but throughout cancer treatment. Next, I'll turn it over to Liza to discuss how treatment decisions are made and how this can impact both functional outcomes and quality of life in head and neck cancer survivors.
Thanks, Carie. And first of all, I wanted to thank Elizabeth and Ed. It is such a privilege to be here today. I can honestly say that the foundation sort of plays a pivotal role in all of the work that I have strived to do as a clinician, as a researcher, And it is just such a pleasure to be here and represent the foundation and what I do. And it's also a real pleasure to be doing this with my colleague Carie, but with Carlos. Carlos for me represents sort of the 360-degree view and real outlook or viewpoint of what I've committed my professional life to, which is helping folks with head and neck cancer. And really this talk illustrates that broad continuum from diagnosis, pre-treatment, along that miserable road of treatment, and then on into survivorship. And getting to work with Carlos through that has just been a joy. And then to have him come back here to the foundation as sort of a beacon of hope and education and information is so rewarding. But let's talk a little bit about head and neck cancer. So head and neck cancer, unfortunately, is the 6th most common cancer subtype. It's diagnosed in over 830,000 people worldwide, with over half of those people succumbing to the condition. Now, there's different types of head and neck cancer. Without question, the most common type of head and neck cancer is squamous cell carcinoma, and that is diagnosed in more than 90% of the total cases of head and neck cancer. When we think about squamous cell oropharyngeal or head and neck cancer, we traditionally think about 5 primary locations where this cancer will present. So we can think about the oral cavity, and that involves lots of different structures: the lips, the tongue, the cheek, the palate. This is thinking about it, this is just a confluence of multiple different activities that occur in the mouth. It can occur all along the pharyngeal tract, starting superiorly at the nasopharynx, extending down into the oropharynx, even lower, more inferior in the hypopharynx and the larynx. Now I want everyone to just look at this drawing for a minute and think about all the things we do that involve these areas. Critical functional activities like talking and breathing and swallowing, they all seem to intersect in this region. Now, Carlos was diagnosed with HPV positive head and neck cancer, and I think it's really important to talk about how that is sort of new on the scene and really provides a very unique way of looking at it from diagnosis to treatment. So HPV positive cancer has been sort of new on the scene for the last decade or decade and a half. The older head and neck cancers, which we now refer to as HPV negative cancers, were most commonly associated with smoking, tobacco use, alcohol use. Thankfully, those cancers are decreasing significantly in incidence around the world, largely because people aren't smoking as much anymore. But interestingly, in the last 15 years, this new form of cancer sort of popped up, seeing a lot of cancers in the tonsil and base of tongue region that seem to behave differently. And it got the cancer team to start to take a deeper dive and look. They found out that head and neck HPV positive cancer, sure enough, is a real thing. And it's linked and has a causal etiology in individuals contracting the HPV virus or infection, which is a sexually transmitted condition. Now, what that also has shown us in studying it is that it behaves completely, well, differently than HPV negative cancers. Even just looking at how we diagnose these cancers, how we treat these cancers, and what are the outcomes of these cancers are different. The people that seem to be most impacted by head and neck cancer that is HPV mediated or positive tend to be younger men, definitely more common than women. They tend to have college education in a monogamous relationship, but really very different than the HPV negative cancers that we saw in previous decades. Now, how common is HPV positive cancer? It really depends on where you live. So here in the United States, North America, as well as in Europe, HPV positive cancers encompass 60 to 70% of all of the head and neck cancers that we see. If you live in different countries, though, the prevalence may be significantly lower. Now, I have had numerous husbands and wives kind of look at each other. There's that uncomfortableness in the room when we start talking about HPV and this link to it being of its origin being in sexual infection or contracted infection. So what it's so important to know is that there can be decades of time between the contraction of that infection and the development of head and neck cancer. But most importantly, we have to know that these cancers are very commonly associated with a significantly more favorable prognosis than HPV negative cancers. Now, I would argue that the beginning of every head and neck cancer patient's journey lies with staging. This is the language. This is the way we define the cancer. This information alone is going to give us and tell us so much about how severe it is, about how it's likely to be treated, and of our expectations and how we're going to help our patients. Now, we've all known somebody with cancer, and we might hear them refer to, you have a stage 1 cancer or stage 4 cancer. Staging is not a one data point formula. It's actually made up of 3 different categories that together go through sort of a flow sheet to develop an actual stage. And that begins with the T stage. The T stage represents the characteristics of the primary tumor. How big is it? Where is it? And therefore that will provide us with a T stage. The N stage involves the degree of involvement of lymph nodes that lie pretty close to that primary tumor. And then the M stage involves or suggests the presence of distant metastasis, so spread to other organs far away from the primary tumor, like the lungs or the liver or the colon. It's the combination of these 3 factors that will provide us with our ultimate stage. And just to highlight how different HPV positive cancers are, it's important to know that the NCCN has revamped staging just for HPV positive cancers for the reasons I shared. They're different. The way they're diagnosed is different, and therefore our outcomes are very different. So in 2018, a brand new staging system was developed. So if you were diagnosed with HPV positive cancer in 2017, they may have told you you have a stage 3 cancer, and yet after 2018, that actually might be a stage 1 cancer. It's still the same cancer, but that downstaging implies that the outcomes, that the prognosis is more consistent with a less severe cancer, which is really fantastic for those diagnosed with this disease. How do we treat these cancers? Now, I can tell you, as a cancer provider in a very large cancer center, that really the treatment options and approaches for cancer in general, I would say decades ago, was very much in a status quo situation, very static. So the primary options for treatment include surgery. So that is where surgeons will go in and remove cancerous cells. And in head and neck cancer, sometimes we can do that. There's radiotherapy that uses radiation to essentially kill cells, cancer tumor cells or metastatic cancer cells through radiotherapy. And then there's chemotherapy, which is a medication that's infused through the body that is also designed, it's a toxic agent to kill cancer. Now, one thing that is very exciting, sort of a renaissance, if you will, in not just head and neck cancer, but in lung cancers and other disease states, is the advent of immunotherapy. Now, immunotherapy is on the rise. You hear it on commercials, but what is it? Immunotherapy is a technique that allows the treatment to harness the power of an individual's unique immune system to do what it wants to do, which is kill this foreign entity, kill this cancer. So this is something very exciting and often possible in certain locations in certain cancer centers. Okay, so how are these decisions made? How do we decide what kinds of treatments are going to be thrown at a patient to help cure the cancer? Is it going to be combined radiation and chemotherapy? Is it going to be surgery and then some chemotherapy or radiation after that? Is it going to be just radiation? Or is it going to be just surgery? How are these decisions made? Because what I will tell you is there is no one-size-fits-all strategy for cancer care. And this is where we transition into this notion of multidisciplinary care, and it all begins with tumor board. Now, I can tell you, coming to an academic center, I would participate in tumor board and sort of sit in the corner and pretend to know what was going on. And I would say for all of the speech pathologists that are out there that are involved in cancer care, that this is something we have to take an aggressive stand to not only feel like we know what folks are talking about, but to have something constructive to add, because our opinions, our perspective is invaluable. And it does take a team to plan out how cancer is going to be treated. So typically at head and neck cancer tumor board, someone will present the case, and the information that is shared with the group starts with staging. It starts with the type of the cancer, the parameters of the cancer. In many centers where you have dedicated head and neck cancer surgeons, the big question is, can we cut this out and can the patient be done? So if there's an option or an opportunity where cancer can be treated with surgery alone, but without significant functional deficits, that's where we come in, then that is an advantageous way to think about curative cancer treatment. But we have to think about the functional considerations. And we as speech pathologists, we know that. So it's our responsibility to chime in and suggest whether or not we feel that that surgical plan seems compatible with functional outcomes. If you work in an institution with clinical trials, always want to present what clinical trials are available. Never want to miss an opportunity to offer a patient a choice. And having clinical trial, having those available to patients is extremely important. We have to take into account that patients are coming into this with their own stuff, their own social issues, their own emotional issues, as well as cultural considerations. Do they live alone? Do they have funding? Do they have insurance? Do they have resources? So these are all critically important things to factor into the plan. We have patients that live 3 hours away. That's going to be very, very an important consideration for us to think about when we plan out how we're going to help them. And then what about other medical conditions, comorbidities, things like that? These are the primary data points that are shared at tumor board. Now I can tell you that our tumor board right now is housed on Zoom, but prior to that, our tumor board was in a very large conference room with a huge table to accommodate all of us, because that reflects the complexity of the decisions and the importance of every contributing member. So in our tumor board, we have radiation oncology, pathology, surgeons, medical oncologists, speech pathologists, our clinical trials team, dietitians, social work, survivorship. But the most important person that isn't there physically, but that we have to report to, is our patient. Now I can tell you, sometimes these discussions are cordial and sometimes they're a little argumentative, but it's all in the spirit of putting the patient in the center to find the best plan. So for me as a speech pathologist, for those of us that are going to be working with our patients to help provide them, navigate them through the process, our plan is to say, okay, this is the curative treatment plan that this patient's going to receive. What can we do to optimize function? And we need to know this. We need to be able to predict it, and it needs to have sort of be woven through the entire plan of care. So the way that I think about my approach as a speech pathologist planning those objectives is first and foremost by reviewing the data from multidisciplinary tumor board. What are the recommendations? Once we know what that plan is, I know with clarity what are some of the sequelae that will occur as a result of those treatments. What is the surgery that is going to be done? Are they going to need a big resection? Are they going to need to be trached? Should I contact my inpatient colleagues to make sure they're applying a Passimir valve and get a objective swallow study while they're in the hospital? Are they getting radiation? Can I see their dosing plan? Do I know what structures are going to be radiated? This information is critical. This is going to help me plan what I need to do to help these patients emerge from therapy in the best best functional way. And then what are those baseline conditions that I need to think about? Are they diabetic? Do they have depression? Do they have cognitive deficits? This is all critically important data. Now, every cancer provider that I would talk to would agree that multidisciplinary care is paramount in terms of the provision of care to a head and neck cancer patient. So being able to see a psychologist and a swallowing expert and a dietitian and someone to manage pain, all of these services are important, essential even. But these patients are inundated with appointment after appointment. It's so difficult for them to navigate all of these appointments. And it is critically important that these services are rendered at appropriate time points along the continuum of care. So at our institution, this is a really busy slide, but what it highlights are all of the services that we provide patients along the left, going up top to bottom, and then the time points going from pre-treatment all the way into post-treatment and beyond as to when those services are going to be administered. And so we have folks that will help us coordinate these visits, that we cohort them so that patients don't see the dietitian at 10 and the speech pathologist at 3. We must make this patient-centric. So they're already dealing with enough. We have to make it so this is doable and manageable. Patients, as I'm saying, have so much to juggle, so many critical components that we're throwing at them. And so why? What is the rationale for all of this? And I will argue that the ancillary component of multidisciplinary care is what will leave with patients, what they will have in regards to those essential critical components of quality of life. So in our program, we provide what we call prehabilitation. Patients see us, speech pathologists, for speech, voice, and swallowing prehabilitation management, both before, during, and after treatment. This is so important because it really does allow us, like I said, to find the right goals, administer the right exercises, and monitor these patients to make sure that we have them exercising and swallowing the whole way through. We offer lymphedema care. This is not only important for cosmesis, but also can have an influence on how structures function because of swelling and lymphedema. We have to be able to optimize and manage nutrition. So I work very closely with my dietitian. Patients see me first, and then they'll wander over to the dietitian right after my appointment so that I can reevaluate their swallowing and then pass along that critical information to the dietitian, who can then work with them to identify the optimal diet. Patients need psychosocial support. I highly advocate for finding a head and neck cancer support group. Patients need to be in close contact with a dental specialist, specifically a dental oncologist if possible. At our institution, we offer this very cool program called low-level laser light therapy, which has been found to diminish or reduce mucositis, as well as dysgeusia. So allowing patients to eat and swallow a little bit more comfortably and with a little bit more enjoyment, as well as physical therapy. So now I am going to pass it back to really the star of the show, Carlos, to talk a little bit about how he made it through the madness of cancer care.
Thank you. As I am listening to the presentation, I'm kind of reliving some of those topics that you are talking about and remembering how it was. I want to go through this madness part that you're identifying it, and say that it was, first of all, it was depositing the confidence in the team, in the entire team. I didn't know, like I said, I didn't know anything about cancer, and I felt very good when you discussed my case in the tumor board, and I was all of this was during the calculations of the radiation and the planning of my treatment. But I was being told by the doctors that my case was being discussed, and it made me feel very confident in the expertise of the doctors, and that my case was being discussed from different angles, and that I was going to get really the best care. So there was, I think that the main thing was confidence. Once I started to get the treatment, I had always the support of my family. I think that I went to all of my appointments accompanied by at least one member of my family, a daughter, my wife, my mother. They were always with me at all of the appointments, and I'm so glad that that all of this happened before the COVID, because I'm sure that the treatment procedures and the access would have been very restricted to family. I got to see the doctors and the team, and not just them, but also even the receptionists, the people that weigh you when you arrive, kind of as an extended part of the team and family. They were always glad to see me. They were always very upbeat, and that really helped boost my confidence that I would get through the treatment. But inside of me, it was having great resolve and great determination to go through the procedure. I also had to manage my expectations, like Liza mentioned before, and I was trying to manage my expectations on the low end, probably. And with the possibility that that I might not get back to normal, whatever normal might be, or that this would just be a something that I would get over with and survive and surpass, really in the way that I did. It was physically and emotionally very draining. In the beginning, I thought that this was going to be very easy. You know, after maybe the fourth or fifth radiation that I had, everything was fine. But right after that, I could feel that there was going to be a slow deterioration of my body. I could feel it, not necessarily of my mind, but my body. And it was like having an aha moment, in the sense of, oh, this is what I heard about all of the people that are having these difficulties in their treatment. I had weight loss because I basically stopped eating. I was being fed through a tube in my stomach, which was also quite hard. And eventually weakness and lethargy set in. So it was difficult, even like to get up and walk. It was a big task. Part of it was enhanced or unfortunately exacerbated by dryness of the mouth and lack of saliva. By then, I could feel that my saliva production was not where it was. And once again, going back to how I got through it, it was with resolve and determination. I had 35 radiations to go to, and I barely made it. I really don't think that I could have done not even one more. The goal was 35, and I made it. During my treatment, I had great difficulties vomiting and keeping anything down. This was probably more than anything my fault. I was given medication for nausea, and between my Spanish and my English, nausea the way I interpreted it was having a feeling of an upset stomach, and when in reality it was to prevent the vomiting. But when it started, it was kind of unstoppable. There were days where I was vomiting 4, 5, 6 times a day, sometimes one time right after the other. So I was losing weight. Another of the hard things was that I didn't want to become a burden to my family. I wanted to be as independent and as participative as I could. And so I was concerned about that, even though I needed it. It was the feeling that I didn't want to be a burden. And finally, another difficult part was maintaining my hydration and doing the infusions. This happened during a time of when it was very hot in the San Diego area, and I was going through dehydration. So concurrent with my treatment plan, I had also to go on to into the infusion center every other day and get hydration as a complement to my treatment. So that was very hard. I mean, they were looking for veins all over the place because they were all being used up. During the treatment, you know, you have an expectation of how it's going to end. So when it did end, the reality is that I was very happy. There were bells at the radiation clinic, and boy, I rang that for with great joy because I was happy to finish it. But I didn't know what going back to normal was going to be. And I was willing to accept that there was going to be a new normal for me, except I didn't know what that would be. I think that my main issue was with eating, that I couldn't pass down a lot of different foods in the beginning because of lack of saliva. But I resolved that by having a glass of water, that always handy. Even to this day, I will sit down for a meal and I will usually have some water or a drink handy, just in case I need it to help push the food down and help with the digestion of it. Also, one of the things that I also kept doing and that I resolved to do, and I still do today, is after following the instructions, are the mouth exercises. They're very important mouth exercises that Lisa taught me about stretching and exaggerating the vowels and making noises. So I'm driving on the road and you know, if somebody looks at me, they're probably thinking, what is this guy doing with all these weird faces that he's making? But those are exercises to help in the elasticity of the muscles and get them toned back to where they should be, where I could eat better. The hardest thing after the treatment was getting back the joy of eating. In the beginning, food just tastes different. There are many foods that I liked, that I liked for many years, but after the treatment, they just tasted different. Even to this day, some of those foods, they taste different than they did before. But it's part of the new normal, and I'm glad to be where I am at. Also, a difficult part is hearing other patients' stories and struggles, and I feel that I'm very, very lucky to be in this position, and that creates an identity of emotion for me. And so those are the difficult things. Now I guess we go to Carie.
Carlos, what a powerful story. Thank you so much for sharing those experiences with us. Now, the fact that the name of our presentation has the word survivorship in it, it's only fair to talk about, well, what is survivorship? For those of you who may not be familiar with the term, Any person diagnosed with cancer is referred to as a survivor. It includes time of diagnosis, periods of initial treatment, as well as long-term follow-up care. Family members, friends, and caregivers are also affected by cancer and can be included in this definition. Simply put, I think of it as life after cancer. Now, where did this term survivorship come from? So there was an ever-growing population of cancer survivors who were living many years beyond their treatment, but experiencing common health issues, psychosocial concerns, late and long-term effects from cancer treatment. So in 1986, the founders of what is now the National Coalition for Cancer Survivorship coined the phrase cancer survivorship. And by coining this term, they were able to create a common language to define and describe the millions of survivors' experiences after treatment. And before the coining of this term, people were called cancer victims, and it wasn't until they were disease-free for 5 years that they were considered cancer survivors. So you can see the potential negative influence this term cancer victim can have on a survivor's outlook and psyche, and it was this transformation of terminology that was instrumental in providing hope and empowerment for people diagnosed with cancer. Survivorship occurs in 3 separate phases that spans life after a cancer diagnosis. Each phase can come with different physical and psychological considerations that the patients may be experiencing. The acute phase begins at time of diagnosis and ends when treatment's completed. The extended phase begins at the end of initial treatment and continues for months to years, and the permanent phase begins several years after treatment. Now, there may be a misnomer that survivorship begins after treatment ends, and some survivorship programs have that structure in place, but here at our institution, we truly believe that survivorship begins at the time of diagnosis. So all patients are referred to our survivorship clinic at the time of diagnosis. This not only allows for better symptom management, but more importantly, to develop that rapport and buy-in that will allow for optimal management and continuity of care throughout the years. A good survivorship program should include all of these key components of care. Educating patients on the appropriate long-term follow-up plan is key. It's vital that these patients receive consistent cancer surveillance, not only to assess for cancer recurrence, but to also look for other primary cancers that can occur. After treatment ends, every patient should receive a cancer treatment summary and survivorship care plan that outlines their cancer treatment and follow-up recommendations, including information on healthy living. Smoking cessation should be considered the 4th pillar of cancer treatment alongside chemotherapy, radiation, and surgery due to many head and neck cancers being associated with tobacco use. Monitoring patients for potential treatment toxicities is a major component of survivorship care that we'll touch on in a moment. Imaging should be done 3 to 4 months after treatment ends to assess the patient's response to treatment. Follow-up for cancer surveillance should occur every 1 to 3 months for the first year, followed by every 2 to 6 months at year 2, and every 4 to 8 months for years 3 through 5 post-treatment. At year 5, it's recommended to be evaluated annually, and at each visit, a physical exam and an endoscopic exam should be done. Part of ongoing follow-up care is consistent screening for common issues such as dysphagia, depression, changes in speech and voice, changes in hearing, nutritional evaluation, and tobacco use status. At our cancer center, we use patient-reported outcome measures to collect much of this data, which are tools or questionnaires that provide information on a patient's health status coming directly from the patient. These questionnaires aim to measure the patient's current health condition without interpretation of the response by the healthcare provider. Critical information is gleaned from patient-reported outcome measures that drives treatment decisions and referrals. For patients who've received radiation to the head and neck, it is recommended to monitor thyroid levels every 6 to 12 months after radiation, as 60% of patients will develop hypothyroidism. In addition, it's recommended to perform a carotid ultrasound every 5 years after radiation to assess for any narrowing or stenosis of the carotid arteries, which can predispose patients to having a stroke or a TIA. Dental health is of utmost importance after radiation of the head and neck, as the oral cavity and salivary glands can be damaged from radiation, as well as patients experiencing xerostomia, which can put patients at lifelong risk of dental decay and disease. It's recommended to undergo dental exams and cleanings every 3 to 4 months post-treatment, as well as the use of a prescription 1.1% sodium fluoride toothpaste or gel daily for life after radiation. Like Lisa mentioned previously, in head and neck cancer, the treatment modalities include surgery, radiation, chemotherapy, or a combination of these, with 80% of patients receiving radiation. And with these cancer treatments comes potential treatment toxicities, which occur at different timeframes across the care continuum into survivorship. Acute toxicities start during treatment and resolve within 3 months afterwards. Long-term effects start during treatment and can last for months, years, or a lifetime. Late effects start greater than 3 months after treatment and can last for an indefinite amount of time. Because of the location of targeted surgery and radiation and the associated anatomical structures and function of the head and neck, these treatment toxicities can cause devastating changes in patients' functional, psychosocial, and emotional well-being. And with these long-term effects, many patients describe this as their new norm, just like Carlos did. Some of these things can unfortunately be permanent despite our best efforts, but some of these things can be improved upon or cured. And this is why it's so important to monitor patients for these issues and provide early interventions so that we can do our best to prevent long-term functional deficits and improve the functional outcomes and quality of life after treatment. Head and neck cancer treatment can also cause psychological and social effects, often from the disruptions in essential functioning caused by physical side effects and sometimes visible disfigurement. Distress, anxiety, and depression are very common. Up to 75% of patients report body image concerns. This can often affect sexual health and intimacy. Going back to work can be a difficult transition when patients are dealing with emotions as well as sometimes disabling physical side effects, often requiring modifications in work duties, compounded by pressure of financial toxicity, which occurs in up to 20 to 40% of cancer patients. Not to mention the needs of caregivers and families that can sometimes go unnoticed. So as a provider, it is of utmost importance to address these potential concerns with patients at each visit and offer supportive care, appropriate referrals, and resources when needed. Now, many people with or without a diagnosis of cancer experience episodes of depression throughout their lifetime. But people with cancer, particularly with a head and neck cancer, have an increased risk of depression with the highest incidence of suicide in all cancer patients and a 3 times greater risk for suicidal ideations than the general public. So this just goes to show screening is really key and should be a priority in initial appointments, during treatment, and at each follow-up visit so that appropriate care and referrals can be offered when patients need it. Fear of recurrence has been found to occur in 31 to 52% of cancer patients, with many of them reporting need for help in coping. In my experience, I feel the incidence is much higher. It is the most common psychological concern I come across in our head and neck cancer survivorship clinic. Because the cancer treatments are so debilitating and difficult, the thought of having a recurrence and going through treatment again is unfathomable for many patients. Ways for patients to cope with these fears include first paying attention to their feelings, recognizing them, sharing these feelings with others, and asking for help. Staying well informed of one's care can be really helpful. Support groups are a great way for people to discuss their concerns and fears with people who understand and have had similar experiences. Finally, 3 ways for patients to prepare what it will be like after cancer treatment. First of all, know that although the visits are very frequent in the beginning and throughout treatment, there will be a time when less visits occur. And some people experience what is referred to as care withdrawal. This can cause increased feelings of anxiety regarding symptoms and fear of recurrence, so sharing the follow-up plan from the beginning can be really helpful. It's important to notify patients from the time of diagnosis of the possibility of these long-term and late effects that they may experience so that they can understand the importance of all these multidisciplinary referrals and the rehabilitation that's required. And that way they can be empowered and informed to improve those functional outcomes and quality of life after treatment. And finally, it's important for patients to maintain their social support throughout the cancer trajectory. Just because treatment ends, it doesn't mean that patients will no longer need their support system. Often they may need them just as much afterwards. So letting patients know about this can be helpful as well. Now, there's a plethora of national cancer organizations that provide education, training, and support for both patients and healthcare providers. Immerman Angels is a cancer support community that connects cancer survivors and caregivers with a mentor who can provide one-on-one support to patients and caregivers who need it. Many of these websites provide information on how to cope with a cancer diagnosis, as well as information on cancer prevention, cancer screening recommendations, information on healthy living, such as diet and exercise recommendations. Cancer and Careers is a website that provides education and resources on how people can thrive in their careers despite having a cancer diagnosis. And finally, the Cancer Financial Assistance Coalition is a website that provides education and resources on managing financial concerns with cancer treatment. And as far as head and neck cancer specific resources, the Support for People with Oral Head and Neck Cancers, or SPUNC, is a nonprofit organization whose mission is to raise awareness and meet the needs of oral head and neck cancer survivors through their resources and publications. There's also over 100 local chapters providing additional support. The Head and Neck Cancer Alliance is a wonderful organization that provides information on cancer prevention, detection, and research. I found their webinars for head and neck cancer survivors to be very informative and helpful in managing some of these long-term side effects from treatment. The American Head and Neck Society's mission is to advance education, research, and quality of care for the head and neck cancer patient. They have an upcoming online conference in July that includes sessions for healthcare providers as well as cancer survivors and caregivers. I know that myself and many of my colleagues are planning on attending, so I would recommend others doing so if they're interested in learning more about this. And finally, I think Ed did a great job of speaking on behalf of the National Foundation of Swallowing Disorders. So of course, this is a wonderful resource for everybody as well. And with that, I would like to hand it back over to Carlos to give us some final words of wisdom.
Thank you very much. I have here a whole bunch of notes, but I think I'm going to cut it down to just the final notes in regards to recommendations for the patients. The patient needs to have just basically a positive attitude. Be glad that you're alive. Be glad that you're able to get this treatment. And believe me, things will get better. Other people may not understand what you're going through, but things will get better for you, and they will get better for your family. Accept it. The new normal can be defined or viewed as a glass that is half full or half empty. Please look at it as half full, because if you're always looking at life and your condition and your new normalness from a point of view of lacking, you are never going to be satisfied. And the reality is that sometimes life you will have to make new adjustments to life. And if you want to have a happy life, go and accept it and make the necessary adjustments. Why am I doing this? Well, I'm doing this because I like Lisa and I like Carie a lot, but also it's my way of paying it forward in some manner to society or to other patients. I don't have the ability to, like I told them, that I don't have the ability to put my name on a building, but if this is somehow a way that I can pay it forward and contribute to patients and knowledge, I'm very happy to do so. I considered myself a good patient, always following instructions and taking my medicines, and that's basically my recommendations for you as a patient and for the people that are on this webinar. Thank you very much for the opportunity to participate.
Thank you, Carlos. Okay, well, like I said, we've come 360 and just want to leave you with a few takeaways. Clearly, head and neck cancer is just a very complex condition that can have a very deleterious impact on individuals' quality of life. But as Carlos said, I love it. The cup can be half full. HPV positive cancer is unique. It's, like I said, there will be more and more of these cancers prevalent in patients diagnosed in institutions, but they have very unique features and they do have improved overall outcomes. Patients should definitely attempt to find a program that involves and includes multidisciplinary approach to managing treatment and all elements of care. Patients, though, do need to consistently self-advocate and they need to be informed. I love patients that challenge me, ask me questions, make me think and want information. That is what I like, and that shows me that this is a true symbiotic process. And patients and families just must ask for help. We all need it. And that's not just to manage physical ailments, but psychosocial ailments that can affect them and plague them, not only during cancer treatment, but beyond. Here are some of our references. And we just wanted to thank you all so much for your attendance. And thank you to the foundation. We really appreciate you guys bringing us here.
Lisa and Carie, thank you so much for your presentation. Carlos, thank you for sharing your journey with our community. We really appreciate it. If you have time, we have a few questions here for you. If that's okay, I'll ask a couple for you, and whoever wants to answer is just fine. One of our questions here, they're thanking you for a wonderful presentation, and they're wondering how important do you feel it is for individuals to work with the same care provider? So for example, the same speech pathologist from the beginning of their treatment to the end of their treatment.
Well, I'll tackle that one. You know, Carie, we're fortunate. Carie is our lone survivorship nurse. And I think that's one of the reasons why we advocate for patients to see her exactly for that reason. Before they start, they develop a rapport with her. They develop, she gets to know them, their quirks, their issues, and then maintains that all throughout into survivorship. For other ancillary services, we make every effort. And I would say it is the rare exception where we do not have that continuity of care that really extends upon every avenue of that service across the continuum. Maybe a few exceptions for vacations or something unplanned, but I think it's critically important because we're making connections. We make connections with our patients. They become a little part of us and we become a little part of them. And so for that reason and many others, continuity is extremely important.
Excellent, thank you. I have a question here for Carlos. They're asking whether your cancer spread to your lymph nodes in your neck.
I think not. I was never told that they did. So as far as I'm concerned, no. With all of the scans that I've had afterwards, they are all clean.
Excellent. And speaking of scans, I have a question for you, Lisa and Carie. In regards to routine imaging, they're wondering if scans are included for patients annually, and
Yes.
if not, why?
Mm-hmm. So according to the NCCN Guidelines of Care, the National Cancer Care Network, there's an indication for post-treatment imaging around the 3 to 4 month mark to assess the patient's response to treatment. Most patients will receive that. Now, outside of that, it is provider specific and patient specific, whether they had features that are concerning that they want to follow up on, or perhaps their cancer was in an area that isn't, you can't actually visualize well in a scope. So of course, like I said, it is patient specific, but there's no real guideline that dictates, you know, you need to have annual scans or at a certain frequency other than at the 3 to 4 month mark. That's a good question.
Thank you. I have a question here for you that says, what category does tonsil squamous cell carcinoma fall under? And I think they're referring, Lisa, to the image that you had towards the beginning of your presentation with the differentiated oral, pharyngeal, nasopharyngeal.
That would be in the oropharyngeal category. And so, and very commonly HPV positive.
Thank you. Another question here for you. Can you explain a little bit about what low-level laser therapy can help with and how it works?
Sure, it's definitely a little in the experimental realm and unfortunately not covered by insurance, but it is a service that is provided by dental oncologists that work on our campus. And it applies a laser light that has been shown to preserve and improve the condition of the oral mucosa. And so there is a company called, I think, Thor, Thor, I believe that's the name. And anyone listening or who has questions can look them up. There's a ton of information on their website.
Excellent, thank you. A question here for you. I'm wondering if the members of the panel can speak to what they call disease fatigue. So any suggestions for patients who are either sick of being sick due to going through the radiation phase of their treatment, or when they still don't feel better and they can't eat, and those who are 10 years post-treatment who are still having worsening symptoms now with eating and communicating?
Wow, I'll try to tackle that. And I think really disease fatigue, I think a lot of it is understanding where you're at. So having a really good understanding of what your function is and what it isn't. And working certainly with the providers to find out, is there anything we can do to make this better? Is this more likely to be a chronic condition? I would always recommend and champion for getting, different opinions and going to centers of excellence, especially for complex cases. I think there's something to be said for psychosocial support and trying to find the space and the ability of acceptance if this is sort of a lifelong condition. I think that's very difficult, and certainly not having gone through that myself, very difficult to manage, but also finding joys. And I do believe that specifically has been something mentioned in our support group, where just being around other people who have gone through the same thing is a bit of a remedy for that exact issue. It just relieves some of the emotionality that is associated with going through something so difficult for so long.
Thanks. We have one quick follow-up question related to the laser treatment. Is this something that's done after treatment or during treatment?
It's done during, and one thing that is really important is, like I said, seeing a dental oncologist before treatment starts. Have to make sure that any dental issues are managed before patients start radiation, and this is critically important. If teeth need to be pulled, and then after treatment, getting fluoride trays, it really goes hand in hand that the relationship between a dentist or dental oncologist and a patient with head and neck cancer is really paramount. So that relationship needs to be strong. I don't believe there are many providers that offer low-level laser light therapy, but certainly can check in your community.
Thank you. And Lisa and Carie and Carlos, I want to be mindful of your time. I'm going to turn this back over to Ed to wrap things up. If there were questions that weren't answered or you think of others, please feel free to email those to us or to the emails that you see on your screen, and we'd be happy to get an answer to you. And with that, Carlos, Lisa, and Carie, thank you so much for joining us. I'm going to turn this back over to Ed here.
Thank you.
I hope everyone benefited from this. The voice you heard and the face you did not see was Elizabeth Lipton. She is the executive director of the foundation and also a full-time medical SLP. So thank you, Elizabeth, for putting the webinar together. Outstanding as always. Lisa, you had a comment about timing of services provided to patients and how important that is. Very briefly, as I was starting my radiation treatment, I was scheduled to meet with a nutritionist, and it was at the very beginning of my cancer journey, and it just didn't make sense to me at the time. So timing is key. Carlos, I want to thank you for sharing your story. A story that is not easy to share. And I'd like to echo your comment about the assault on your body without impacting our mind. And that's a little bit hard to get a grasp on sometimes. And Carie, that was a great framework for understanding the components of survivorship. So all of you, Elizabeth, Carlos, Carie, and Liza, thank you so much for your time this evening. If you have a question that wasn't answered, please email us and we'll get back to you. You will get an email within the hour. It has some links in it. And again, if you know someone that can assist and complete her thesis, I encourage you to do that. Our next webinar is on Wednesday, July 7th. With that, I wish everyone a good evening or a good day, and I hope to see you again next time. Good night, everyone.